Good morning, everybody. It's a pleasure to be here. I have a lot of slides, and the advantage of being from the West Coast, Alina sent an email yesterday at night, allows you to add more slides to address some of the questions that she asked. So I want to briefly talk about IHME because we're very new, talk about one of our main products, a global burden of disease, some other relevant IHME projects and products that may be relevant to you. But I want to zoom on the US burden and give you some brief recommendations. I'll skip some of our slide. What we do is the main global burden of disease is a systematic scientific way of measuring health loss, and we do it for every country in the world, and for many countries in the world now we do it at the subnational level. We cover 359 diseases and about 3,228 sequela, so diabetes amputation, diabetes eye loss, vision loss. 84 risk factors. We do it from 1990 to 2017. We have a large network of collaborators working with us on every topic or country-specific data, so that's one of our strengths. Briefly, what is the global burden of disease? In addition to traditional metrics that we provide, incidence, prevalence, deaths, we also have three measures. So the first one is years of life loss. So if you take the highest life expectancy in the world, Japanese woman at 86, somebody dying in DC at 60, that's 26 years of age loss. We add them. We can contribute that years of life loss to a disease or a risk factor. So we can tell you how many in a state died from lost years due to diabetes and so on. Years lived on disability, which is very important, is somebody at age 60 in DC getting diabetes, living with diabetes for 10 years. We assigned, depending on the severity of that disease, disability was it. We added, and we could provide diabetes by disease, by risk factors. So the first one is what's killing us and how early it's killing us. The second one is what ailing us, which is very important. And the combination of the two, this DALYS, which is a good measure of health of a population. And the last one is healthy life expectancy, which is your life expectancy minus the years lived on disability. So how many years somebody lives in a healthy status. And it's very important to report. All what I'm giving you today is available on our web, the data sources, and we're part of Gather at IHME. Even the programs that produced a number are available for everybody out there. Very complex methodological, we're not gonna go through it, but I'm a professor, I have to have a slide about methodology, but here we have all our risk factors or all our diseases, you can break it down. So you have non-communicable diseases, you have cancer. Within cancer, you have all types of cancer, 23 at this time. Then for some of the cancer, like liver cancer due to hepatitis B, due to hepatitis C, you can query our data as deep as you want as well, and you could group it. Same for risk factors. If you're looking at diet, we have 14 components of diet, and then you could group it to look at diet, for example, and then you could group it to look at behavioral risk factors. Yesterday, the email, Elena mentioned something about score, evidence score. So most people in our business use something called the grade for evidence. And if you go to their webpage, they tell you grade is subjective. We at IHME use the World Cancer Research Fund for the evidence score. But again, it's very subjective, highly subjective. Right now at IHME in GBD 2019, as Ed mentioned, we give a quality score for all the data sources, because in our business, as Ed said, it's not collecting a survey, it's the quality of the survey. So we give for mortality data, we give a score for every data, for every country on their data, and now we're doing an evidence score for the risk factors to the disease. So we will allow our data user right now, when you look at our burden of disease, you could decide what strengths of evidence you want to use. And that's very important. A lot of work is going on that. All the data, again, is available on our web. What's really unique about IHME, not us, but other people do this, we have clinics data. So we have hospitalization data, 7 billion clinical encounters from 47 countries that we use in our global burden of disease, which is very important. And we have many countries right now, including the US, Mexico, and Brazil in our area, that we're providing subnational data for GBD. So briefly, some of the products that we do at IHME. One, we report on the Sustainable Development Goal. We do it for every country, and we do it subnationally as well for the countries where we have subnational. And the beauty of what we do, we don't report 2017, we report 2030. So we tell you what's you're going to be, how you're going to achieve it or not. And we can give you the projection. What of these indicators, 42, you're going to meet yes or no as a country. And here Singapore is the highest, 85. USA scores 74, 0 to 100, being 21. And Central African Republic is number 12. And then this is the map of the Sustainable Development Goal by the SILE in 2017. Countries in Africa, you could see Western Europe, Canada does better than us. The most important message here is subnational variation. So here is SDG at the state level for us, and you can see a huge variation within the US, from Louisiana to Minnesota, for example, California, and where I live in Washington State. We do health access and quality of care using mortality. John Skinner was talking about this. The health access and quality uses mortality. So certain diseases that you shouldn't die from if you have good access and quality. So it's a combination. We cannot separate them. And this is, we provide it for every country in the world. We provide it at subnational level. We rank countries as well. The message here, even in a country like us in the United States, a huge variation between health access and quality of care between states. We trace all the money and the finances. In the US, we could tell you where the money is coming from, out of pocket, how much, what is being spent on. We could even decompose in the United States. I'm sorry, I'm going briefly about this because I want to tell you what we have. Take more questions, happy to continue by email. But here we can decompose like increase in cost due to aging, growth of population, increase in cost, drug cost here is the big, and we could see a shift from inpatient to outpatient spending here where our hospitals have realized we're not in the hotel business. You come in one day, they do all their tests, they move you to outpatient. So, and we do something we call geospatial, where we provide 5 by 5 kilometer certain indicators of grant from the Gates Foundation. We do what we have now, future health scenarios, where we take every burden of disease and we project it to 2040. We do it to 2030 for SDG. And the idea here is not only to provide you where diabetes would be in 2040 in the US or 2030, but what if scenarios? If a state change obesity by 5% decrease, what will happen to that burden? Now I'm going to shift to the US burden of disease. We published this in 2017. GBD data 2017 is available. I couldn't run some of the variables because of our cluster is busy running something else. So I'm showing you the 16, but the data for 17 is available. So here, DALYS, showing you the diseases in 1990, in 2016 in this case, and show you age standardized, age and DALYS that change. So you could account for the age distribution change here from 1990 to 2017. And you could see, for example, COPD is increasing, diabetes is increasing in the United States, opioid, of course. But you could see ischemic heart disease is declining at the age standardization. If I show you this by state, there are huge variation by state, of course. We can show you risk factors as well from GBD. Tobacco is number 1 in 2016. This is both sexes. High body mass index, diet, alcohol, and drug use follow. And you could see the decomposition here. Tobacco, what's contributing to cardiovascular diseases, cancers, and so on, the color codes on. On our web, you click on it, you could get the number, and you could see the changes as well. But the most important, what we did in this JAMA publication, we showed the probability of deaths in 1990 and in 2016. So the dashed line is 1990, as you see at the bottom. 216 is the probability of deaths in 2016. So this is ages 0 to 20. The probability declined, progress across every state in the United States, variation in the level of improvement. 20 to 55, it's a totally different story. In 21 states, the probability went up or stayed stagnant. No significant change whatsoever. And here, this is very scary. This is a productive age group where we have seen the probability of mortality for 21 states has increased. And the composition here, hard to see on our web, you could see it better. It tells you what was the leading to the increase of the probability on the plus side and what's the led to the decrease. And here, as you would expect, drug use, diabetes, obesity are driving risk factors here and diseases as well. 55 to 90, there was improvement in every state. So huge variation by state, by age, by sex, of course. You could rank in GBD the causes of DALY by state, which in Alabama would be like tobacco and so on, like in California as number 4, tells you what California did in order to fight tobacco is a been aggressive and has made tremendous improvement in that. Projection to 2040 in life expectancy in the United States, and you could see Japan is number one, will remain number one in 2040 here. The rank of the United States will keep declining. China is improving, and that's a very important message to show. In fact, in 2017, our life expectancy in 2040 will be lower than a Japanese woman in 2017 for our female in the United States. And then we could do a decomposition of what is really causing that change. Again, the same what I showed you for the 1990 to 2016. You could see here the middle line, that black is where you would be in 2040. The red is if we perform at the 85 percentile, and the lower is if we perform at the 15 percentile. And that's very important. We're providing you where you will be in 2040 and what if scenarios, if you perform at a certain level and if you perform at a worse level. And the message here, that the health gain that we have seen in the United States, we cannot take for granted. We could go back in any way. Healthy life expectancy, this is the United States by state, and I'm showing part of the south borders here. One of our states is the worst all the way except for Haiti, 56.3. West Virginia is 62.5. Cuba does much better than many of our states, in fact. So that's healthy life expectancy. Huge variation in our states, but also we perform far worse than our neighbors and here. If you look at life expectancy in the United States at the state level, 75 and 81 in Hawaii, 75 in Mississippi, but if you go, and 2014 was the last data we had. We have now 2016, and we're running this analysis. So you could see even a wider variation in life expectancy at the county. I don't know what people in Colorado do in Summit County. They always stand out, and they're doing much better than anybody else. But you see huge variation, much larger than the variation that we see by state. In global health, Oklala, will be something similar to what we see in Africa, Western Africa. And the disparity between the 1 and 99, I'm not taking the outlier, is increasing with time in the United States, between the lowest and the highest. So it's really increasing. We're not going in the right direction when it comes to disparity. And we have on our web lung cancer mortality, for example, at the county level, huge variation per 100,000, 232 to 10 in places. And you see the change from 1980, in this case, to 2014, that many counties, the probability of mortality is increasing. In many places, it's coming down. California stands out, of course, being aggressive on tobacco. You could see Hispanics don't smoke as much as the rest of the country. But here is a risk factor. I could lag smoking, which we have on our web, smoking by county, and you could see this is a direct relationship to a risk factor in this case. Drug use disorder, tremendous increase in almost every county in the United States. There's a huge variation in the rate of increase from 1980 to 2014. Testicular cancer, nobody should die from it if you have access. Very low burden, but tells you that many people in this country don't have even access to health care. They shouldn't die from these diseases if you have good quality. Breast cancer, a combination of screening, access, and quality, and some risk factors. Again, we see a huge variation in our breast cancer, where some counties going, improving, where counties are increasing in terms of mortality, again, from breast cancer. Same applies within the census tract, and we did this for King County, where I live. It's a rich county, Amazon, Boeing, Starbucks, you name it. But still, you see huge variation, where you see a life expectancy increase within 5 miles. Yeah, I'm done. So what I explain is, I'm not going to dwell on those. What we have done is showed that risk factors contribute to 74% of inequality and risk factors, whereas socioeconomic alone 60. And again, life expectancy is my measure here. So regardless of what we have shown in the United States, We're performing much worse than our competitor and many of other countries. Life expectancy in the US is lower than when I came from in Lebanon, and we have a civil war in Lebanon. And large disparities are accounted mainly by risk factors here. And socioeconomic are important, but manifested through risk factor. What are my recommendations for you in the last 10 minutes? Stay global, so include some SDG. It's very important not to shame our politicians to do what they need to do, but also to see what countries have faced challenges and they were able to overcome them. We need to learn lessons from other countries. Use future health scenarios when you report 2030, not interim, doesn't matter. Where you're going to be in 2030, what if scenarios? HAIL, under 70 mortality, working force, 20 to 64, you need to provide their health. It's very important to link health to other outcomes. Time of medical intervention, Bobby mentioned the ambulance coming to your house. It's very important for us. Disparity, so you need to go local. And please, please focus on risk factors in the United States. And then thank you very much.
Thank you.